Amazing. So they've given me a little step because obviously I was too short last time when I stood up here and none of you can see me. Thanks so much for staying through to the end. It's really appreciated. So this talk is probably a little bit different to the ones that you've heard so far. So we are trialling SafeRT in one of our sites in the UK. So I'm going to talk to you a little bit around automation in radiotherapy and what we've done after the sort of rollout of Align RT and introducing SafeRT into one of the centres. So disclaimers, I don't have any Vision RT, have paid for my flights and accommodation while I'm here, but other than that, none. So just going to talk on a little bit around what our Genesis Care and what do we do. I've got a nice patient story that sort of sets the scene around why we want to automate more. Talking about automation in radiotherapy in relation to SGRT and SafeRT and how we've used it to mitigate risk in some of our centres, how automating can improve efficiency, allowing us more time with our patients, certainly automation in breath hold, time savings, and then I couldn't stand up here and not mention tattoo-free treatments, even though I've talked about it all afternoon with you all already. So Genesis Care, what's our purpose is to design care experiences that get the best possible life outcomes. So we think about that with any project that we implement, and SGRT and SafeRT are no different to that. This year we're going to be in charge of treating more than 30,000 patients globally, so that comes with a responsibility to continuously evaluate what we're doing and make sure that we are driving services for our patients and continuously improving everything we can do, right from workflow through to new equipment that we're implementing. So I'm just going to, the next slide is a nice setting the scene from one of our patients treated over here in Australia called Wendy.
I'm Wendy Tom, I'm 32. I'm a mother of two and I live in Lang Lang. Actually, Christmas night when I was laying in bed with Lee and the kids, I felt a lump and I said to Lee, "Oh, can you feel anything?" And he goes, "Oh, I think you should get that checked out." And I remember the day of the diagnosis, I was at work and I said to my colleague, "So I'm going to get the results today." And he goes, "You'll be fine, you'll be fine." So I went to the appointment to get the results by myself because it wasn't going to happen to me. It was probably the hardest thing, was telling Lee. Got the results on the Monday and on the Wednesday I was in for surgery. We got the diagnosis of stage 1, grade 2. So thankfully it hadn't spread anywhere. Met with my oncologist. She gave me the option of chemotherapy and I decided to progress with that. I didn't want the kids to see me sick. That was tough to know that they're going to have to see me like that. But yeah, I'm glad I did it. I did 4 rounds of chemotherapy. My oncologist then referred me to the radiation part of my treatment. The thing that helped me the most was asking questions. Once I'd met with my radiation oncologist, he actually asked me my story right from the start. So he wasn't just concerned about what he had to do. He wanted to know who I was, what I'd been through. Leading up to finding out that I was in remission was quite anxious, as anyone is. To hear those words, it was all clear, was wonderful. I think Genesis Care are really taking steps forward in this area to provide a patient-focused service. My advice for someone going through a similar treatment would be, it's okay to let people come in and help. If you need half an hour to just sit, that's okay.
What she felt was really important to her at that time of diagnosis and then through her treatment. She's a young lady, early 30s, couple of kids, and actually the diagnosis was absolutely utterly devastating for her. She talks a little about how Genesis supported her through that, and that the main thing for her was having the time with people that could sit and talk with her. We heard this morning again around the explanations, the time taken to care for patients, not just to deliver treatment, was super important. And Wendy sort of sets the scene nicely for automation around that. So when we talk about automation, obviously it's controlling processes in order to increase reliability and efficiency. 2 distinct aspects: introduction of computers into processes and implications on humans. So when we talk about automation in cancer services, from staff, what we don't want is people just to think that automation means that we're going to have job cuts. You're not going to need us anymore. That is absolutely the opposite of what we're trying to do here. What we're trying to do is automate all those manual processes like ID procedures, asking patients the same data day in, day out for 37 fractions sometimes, actually taking those away, making that much more efficient so that we do have the time to actually have human time with people, answer questions that are really important to them. If you look at massive industries that have used automation really effectively, you can see that aviation do, manufacturing do, medical certainly, but we reckon we can go one step further and certainly reduce some risk with the introductions of products like SafeRT. So where do we start? So SafeRT, we, as I said, have installed this at Cambridge. It helps us to ensure that we've got the correct patient in the bunker every day, that they're correctly identified at CT, in the waiting room, in the treatment room prior to their appointment and prior to radiation delivery. It also allows us to be able to check that we've got the correct immobilization accessories on the bed for our patients on every fraction. So the way that we do that is we have handhelds. They're actually little iPods that are mounted in medical casing. We can see that as we go out to the waiting room, we help to maintain confidentiality by not shouting patients' names out across busy waiting rooms. As you can see, this waiting room is not busy. They don't look like that always. So we actually use the facial captures that we take at CT to identify our patients and bring them straight through for treatment. It means that we never even get the wrong patient into the room, even before we have to do date of birth and full ID procedures. And it's really simple and quick. All our therapists have these in their pockets at Cambridge. Works really well for IDing patients in the waiting room. Then onto CT. So at the point of CT, we would ID normally. We do our 4 points of ID. We would capture them into the software at that point. So we take a profile picture, just using the iPod, much like you'd use your phone. And then we use that, as we just talked about, in the waiting room. The system uses facial recognition. So we have a facial recognition sensor in the maze in our bunkers. So after we've done that initial capture, every time the patient walks down the maze, it will actually confirm that that's the right patient that's headed into the treatment room for their radiation. And we're working with Vision RT at the moment to work on that integration through Mosaic. So when we call up a patient record, it will automatically call up in SafeRT. And that's very soon, in the next couple of weeks, going to be the case. So when we're at CT, we can enroll all the accessories for a patient. So when we bring them in, we capture their face. We create them within the software. We'll complete the planning CT scan as we would normally, and then we then go and capture every bit of immobilization equipment that we need to treat them daily. What it also gives you the functionality to do is capture individual bits of equipment, so mouth bites, custom bolus, whatever it is. You can create specific barcodes for those patients as well, just to make sure that you don't omit those in error actually on the bunker. It won't let you progress until you've captured them all daily. So it's really fast, it's really efficient and completely safe. So changes in automation for normal radiotherapy treatment. When we looked at SGRT, I mentioned earlier, we looked at it from enhancing our technology. We wanted to improve patient safety and also improve patient comfort. We've obviously improved our breath hold service across all sites, and we saw SGRT has superseded what we had already from a patient serviceability perspective and a patient comfort perspective. We do see massive benefit in the system for intrafracture motion management. You'll have heard at various talks all through the afternoon too, around we just get more data now with these systems than we've ever seen before, and we then continue to update our workflows based off that data. And then the reporting and data analysis tools are super good. I would encourage you, if you get the system, to delve into those as part of sort of rolling out the system. We have improved throughput on the clinic. I'll talk a little bit more about that. We can treat more patients through the day, so more patients can access really high quality treatments. And as everybody said, we see less repeat imaging just because we're using the system to set up much more accurately than we ever could with 3 tattoos and lasers. So I don't need to harbour this point. We've heard lots from a lot more clever people than me around how the system works, but the benefits obviously are it's non-ionising. You can use this on every patient. There is no harm having this on for every patient that you treat, whether it's an extremity, a chest. having that information, even if you're thinking about changing immobilisation equipment, have it on, because it will just give you so much information around, actually, are you immobilising as well as you think? Use it for setup, interfraction motion management. It just ensures that you can't physically treat the wrong treatment site using this system, because your deltas will just be way off. Again, we've seen this image a couple of times, but that's how the cameras fuse all the pictures. The system uses 20,000 data points as opposed to 3 or 5 tattoos, which obviously, as you've heard, makes setups much better. Real-time monitoring is super important, especially when you're talking about DIBH. The system we had previously, the radiographers were in charge of manually switching the system off if the patient's breathed out. With this system, it's fully automated. Align RT drives that machine to switch it off, so you take the ownership, again, through automation off the staff. So we've talked about this a little bit. Again, from this morning, we've moved away from this sort of labour-intensive DIBH solution using spirometry, moving kit on and off the bed, plugging things in and out of the wall, patients struggling with a spirometer, over to a really quick and easy DIBH solution. This is super, super easy for patients to use. I mean, have a go yourselves. You can capture referenced images of yourselves in free breathing, take a breath in, capture, and see how easy it is to go back in and out of breath hold. We did a lot of self-testing. We did a lot of seeing if we could con the system if we back arched, you know, how sensitive is the system. The only way of knowing that and convincing yourselves is to do it. And I would totally suggest getting your systems in early and play around with it before you start with patients. I did have a nice little video here of how the system works. I'll run it and I'll talk over it because we're not going to be able to see. But this is a training video that we created just to show how the system works. So you'll see 2 of our radiographers here setting up, actually one of our PAOs, one of our admin staff. The equipment there they're attaching is the real-time coach, which I'm sure you've seen in the demos. So we free float. We pop our lasers on, free float to a proximate position, and then move over to the system and start monitoring. So you'll see here the patient obviously isn't set up properly. The deltas are going to go out in a little moment. So lasers over approximate position. Now moving over to the system for setup. This video was made before we had our Couch Move Assist functionality working. So this now is all driven straight through the LINAC. We send the shifts straight from Align RT and ASU to position. So we've not got the radiographers standing, having to flick, long and vert. So this is now speeded up. Once we're happy with the positioning in free breathe, you'll see now that they're going to pause and swap over to the breath hold surface. And again, these will be DICOMs, the VRTs, because this isn't actually a patient. So then we're going to coach the patient to move the bar into the other bar. They take that nice deep breath in into the bar. The radiographers will be looking at the deltas on the screen and they'll literally flick off any residual lat and long. Never adjust the height because that will adjust your breath hold level. You'll see them do that just now. So the patient breathes in. They'll just flick the couch that last couple of mils for the long. Once it's all within, depending on the patient, they might repeat that process a couple of times, especially if the patient's quite anxious. If it's a patient that's away through treatment and you know they're going to be fine, we will only do that once and then we'll head out. So move the gantry round to imaging position. At that point, radiographers will leave the room when they're ready for imaging. They coach the patient into breath hold from outside, CBCT, make any shifts with the patient in breath hold, and then we carry on. I'll just flick through. So then some of the time savings that we've seen, before we had SGRT and we had spirometry, we used to have to get our patients in for about an hour's prep session, even before we did the CT. We'd need to coach them, get them used to the spirometer, talk them through. Obviously, it's quite a lot to take on when we strip them of all senses. So it did take quite a bit of time. We used to have quite a lot of non-compliance where we'd need to send patients home to practice with the spirometer and come back. Since SGRT, obviously, we've dropped that prep visit. We do still continue to coach our patients, and that's really important, even with SGRT. the patients need to understand that their position needs to be reproducible. Obviously, most of them are very anxious at the time of CT, so it's worth spending that 15-20 minutes with them at CT to tell them it's important that you relax your shoulders down. We always coach using a really slow inhale through the nose. We don't have any open mouths for breathing, and that tends to be much more reproducible. We don't get people taking big gasps and then settling. So it's that real slow coaching, and do spend that time at CT. But you can see here that our appointment times went from 20 minutes in the bunker down. We actually schedule 10-minute appointments now. But actually, when we look at the data, which we are quite good at doing in Genesis, we can see that from the time that we switch the AlignRT software on to the time that we close it at post-treatment, we're about 4.5 minutes. So that includes setup, that includes CBCT and analysis, and it includes treatment. So you can get really, really slick with these treatments. Do not expect that the first sort of 6 months that you go live. You'll probably find that you'll need a little bit more time while your therapists get used to the system. But once that sort of knowledge and know-how around the system is there, you will get really speedy at setting patients up. And then tattoo and marker-free treatments, we've had a whole session on this afternoon, but it is super, I feel really passionate about this. We have systems now available to us that are not only more accurate, quicker to set up, we don't actually need tattoos. And if you have these systems, we should really be thinking towards, from your patient's perspective, if they don't want them, we shouldn't be giving them tattoos. There's lots of evidence sort of emerging now around body confidence and body image, and that patients that don't have tattoos 6 months post-treatment have a much better body image than patients that do. And that is all real data that's being collected on real patients where centres have gone tattoo-less. So I'd urge you to have a little look at that and see if you can drive your own practice using that. And really sadly, I had a lovely video here from one of our patients in the UK that talks about, I'll let it run because I think it's subtitled, but she talks about how her cancer diagnosis, she coped really, really well with it. But actually, she said when you get that diagnosis, everything feels out of control, like you have no control over everything. You're told you've got to go have surgery, you've got to go and have chemo, you've got to go and have radiotherapy. And she said having tattoos for me was one of the biggest things. It was just another thing that she had no control over. And it made a massive difference to her not actually being able to grapple back some of that control, even if it seems to us something really minor. For her, it was a massive deal. It's a shame that you can't hear the audio, but I can forward these slides on if anyone's really interested. See, again, she's saying there. And that, so in conclusion, we're managing to automate quite a lot of our processes now. Certainly the ID one is, we all laugh about patients who say to you on fraction 30, seriously, Jack, you've asked me my name and date of birth and address and what I'm here for the last 30 days. Do you not know by now? And it is just actually that whole thing, if you can automate it and remove that manual process, it gives you the time to then ask the patient, hey, how was your night last night? How did your kid go with their exams? And they feel it makes the whole experience a lot more personable and a lot less clinical. So, that's about it from me. Any questions?